Welcome, everybody. Today I'll be talking about digital dentures, new materials and new techniques, exploring the latest advancements in denture materials and how they can benefit your practice. But before I do start, I just want to thank all the companies that progress and push education forward, along with the people here doing the recordings. This is always great because education is the key to better our whole industry. My name is John Orphanides. Everybody knows me as Johnny O in the industry. You can see that's me. I'm 8 years old. My dentist brother's there. The rest of the family's in another part of the lab. I'm 54 years old now. I'm a generational lab technician. I was fortunate enough to bring exocad into the USA. I was a former research associate at Tufts University and did all the 3-year and 5-year studies for zirconia. I taught CAD technology to the postgraduate department, prosthodontics at Tufts University with Dr. Hiroshi Hirayama. And I'm the founder of Amerident Dental Laboratory in Florida, which we established in 2021. I want to get into this because dentistry is my whole life, and I love this picture because even from prior to having real dentists, there was always teamwork. I love the kid holding the guy's head in the back, and it's just a great picture of how far we've progressed in dentistry. It's real awesome. It's really important to understand what we're trying to do. A lot of people talk about teamwork, and you know, there are the few that really believe in it, but it's not only about teamwork on a personnel level or a human level. It's also this attachment to workflows. It's really important to understand how one part affects the other, and same thing with materials and chemistry, and even important things like manufacturing machinery and things like that. So, you know, if you don't understand the purpose of why you're doing what you're doing, you'll never get to this. This is teamwork with a purpose. If you've ever seen one of these watches totally blown apart, you would see how intricate and detailed they are, and every little part plays a role. So we'll talk a little bit about the advantages of a digital denture, but I want to define it first. And this actually is a rhetorical question. So what is a digital denture? I want you to answer it for yourself. Is it one that is made by hand and then digitized? Is it scanned? Is it a scanned model and then designed and milled or printed? Is it a denture that was scanned and then made new? Is it a copy denture? Is it one that came in the analog or digital format and then it was digitized and made? So the point here is that there are a lot of different variations of what a digital denture is. So the methods of digital transfer or digitizing dentures, there's many ways. And we want to make sure that we understand the process. But is it the impression or the process? Do we have huge failure rates today when we're doing this digital world? Well, so we can start off with something like this, which is basically an impression. We can definitely scan, and we'll talk about some of the pitfalls of scanning edentulous patients. And we'll go ahead and see how we do a reline of a previous denture and how that can help us. But does it really matter? Because the way we capture the data, the method really doesn't matter. Accuracy does, but the method really doesn't. Because at the end of the day, we still need to provide that patient a prosthesis that they can actually use. And we all know that dentures have been a thorn in everyone's side from the beginning of denture manufacturing. And we'll go through a little bit of denture history because I think it's important to understand where we've come from. So the process of denture fabrication, analog or digitally, no matter what happens, Number one, we still need impressions or surfaces that we're looking for to fit our denture parts or digitized dentures or impressions to make an analog denture. We still deal with how to restore this patient that has an old worn denture or teeth need to be removed for a new denture, replacing the pre-existing condition like an immediate. Since 1937, believe it or not, we've been using PMMA and a PMMA-based material. We also have to understand the points of how is it going to be manufactured. Are we going to do it 100% digital, 50% digital, 100% analog? We don't know that. But today, what we're talking about is that these dentures are being injected with PMMA, so polymethyl methacrylates. And, in the last probably 2.5 years, printing dentures has just exploded. So the first time I printed a denture was probably in 2015. We were the first guys to print with fibers. We'll talk about that too. And I'll just talk about sort of the progression of where we are. The other thing too is something that I want all of you to really think about being clinicians. I'm sure there's probably a few technicians out there too listening. How often will it need to be replaced? And so when we think about this situation, we look at it and say, okay, so we've had old dentures in the past, and the general word is, hey, we need to change them between 3 to 5 years. But do we really have to change them in 3 to 5 years? Let me throw this out at you. Imagine if we can tell our patient, why don't you come in the beginning of the year, January 2nd every year, and I'll just give you a copy of what you had. So you're not going to have any wear on your denture. The intaglio surface or the tissue fitting surface on the alveolar ridge may or may not have changed. And these are things to think about, saying, well, if I have a patient for 5 years and this is actually starting to wear, is that causing the alveolar ridge to start resorption? Because it's not fitting great now. Now our bite registration is different. Just some things to think about because of the digital world. So the advantages of utilizing digital dentures is that, really importantly, is once the work is done, it can be duplicated as many times as you want and can be transferred to different methods. So if you've done it in milling, you can print it. If you've done it in printing, you can mill it. And there's different ways of approaching on how to make that happen. So we all know one of the biggest difficulties is how to take an impression for an edentulous patient. There are a few doctors that understand Gothic arch tracing. And when I say that, the first thing you think of is a ball and chain with spikes on it because it's archaic. We talk about border molding and compound. It's difficult, but there are techniques that can really help. And some of these techniques are just utilizing what the patient has. So for example, if you're making a new denture for a patient and they have an old one, just have it scanned. So even if the patient loses it, you have a copy, and it doesn't matter if they lose your new denture, you always have a reference and a master copy for that denture so they can at least have their old one. Or once you've completed your denture, you can scan it yourself or ask the lab to scan it for you. So your work now is saved and reproducible. So all that time you've taken to take impressions and take bite registrations and do the wax rims and all that procedure, if that's the way you want to do it, then it's great. All that could be copied and you don't really have to do it again. The secondary style happens much easier and faster. But one of the most important things that I really want to stress, and at least have you take away one thing today, is accuracy is the key. And it not only enhances precision, but at the end of the day, it's patient comfort. So if we're accurate in what we produce, the patient is going to be extremely comfortable. So going back to just one point about border molding and taking an impression, I know that a lot of people are looking for the fast and easy way of a technique to manufacture something. I can promise you there are easy ways of doing it, but are they good? No. Are they good enough? It all depends. Are you asking your patient, or are you asking yourself or your mom? So these are the things that I think also hit a little bit ethically, but I just want to let you know that accuracy is super important. So how do we utilize a desktop scanner or an iOS for a digital denture? Well, if we have a desktop scanner, you just go ahead and scan it. But this is, in our findings, we believe, some of the best solutions to process a full denture or even a single denture. When we go into immediates, it's a little bit different. It's not more complicated. It's actually a little bit easier. But let's just go through this. So number one, you want to check the dentures for any cracks or the teeth for any chips or wear. Check to see if the denture is fitting, if the denture is fitting well. If it is, you're in a good place. If it isn't, then take a wash impression in that denture and use it as the best custom tray ever. On that point, I want to make sure we all understand that the mouth is an environment. We have the tongue that doesn't stop moving, doesn't get tired. We have our lips, our cheeks, we eat, we speak, we swallow. And so it's really important to understand that these ideas of border molding are there for a reason. They're not just, hey, let me just take a scan and make a denture, right? So when you are doing this wash impression, you may want to use it because it's a really accurate prosthesis that the patient has been wearing, that now you can actually make it fit much better with the wash if you border mold just a little bit, even with some of the heavy body material. After the wash is taken, scan the denture and the opposing arch and the bite scan. So you have the denture in the mouth. You scan the denture, even just the teeth side, and then go ahead and do the opposing arch and a bite scan. Now we have positioning, and it's really important to understand referencing. Then take the denture out of the mouth, scan the denture all around. So it would be the inside and the outside, the intaglio surface and the occlusal surface in 360 degrees. There are some tips and techniques that others have brought to the attention of many people doing these scans. So you can put a little squiggly line either with wax or some quick composite on the smooth tissue surface. That helps usually with scanning because the scanner is looking for topography. So it needs to see something a little bit different so you can get a great scan. Position number 6, you want to communicate on the prescription with your laboratory for aesthetics. For example, pictures. You need properly taken pictures, not sitting in the dental chair, a 3D scan of the face, and any other important data that the patient needs. And let's be honest, today, it doesn't take much. You don't need a $12,000 camera to take a picture with perfect lighting. You can use your iPhone or your Android. It doesn't really matter. There's no reason in today's dentistry, with all the digital power we have in the laboratory and in the dental clinic, that we can't practically make an awesome denture the first time around. At this point now, all the data that you have and that is needed for a new denture is ready. You're ready to go. So how do we qualify an advancement, right? Why do we want advance, or how do we know it's an advancement? Well, even if the dentures are packed or injected, if they're milled or printed, these all still need to be reimpressed, eventually relined, repaired, replaced, reset. Patients need to be recalled and reappointed. And so to get to the question of how do we qualify an advancement is it making us more accurate? Is it faster? Because faster and efficiency is an important quality. Is it better? Are the materials better? Is it fitting better? Do the patients have a better experience coming? Do they have to still visit you 20 times for a denture? So hopefully that won't be the case. But in the end, the benefits of the digital process are irrelevant if the data sets are incorrect, incomplete, or unusable, as they are equally in analog processing. Do you know on a regular basis, we get finished dentures on alginates with no border molding? They're short. And the reason I'm telling you is that it doesn't matter what we do. I can guarantee you that our product is going to fit on the model perfectly, but I can also guarantee you at that point that it's not going to fit perfectly in the patient's mouth. So if you're going to do this, you might take heed of what Yoda says: do or do not, there is no try. One of the huge things for dentures is the reduction of chair time. And so we all know that usually in the geriatric world, these patients come in, it's difficult to treat them. Some of them have a shaking problem, or they have a disease. And what you're trying to do is give them the best oral care you can. And so if you take the time to understand why you're doing what you're doing, and you understand the process and the workflow, and you have it on a sheet, and every step of the way, you can not only reduce your chair time, but I can guarantee you'll make everybody happy. Basically, visit one, the patient comes in for a new denture and they have an old one. You check the fit, you ask about aesthetics, you take the data required for a new denture, like we just talked about. You send it to the lab, or you can go ahead and try it yourself, and we'll talk about that. Visit 2, you basically insert the denture and possibly a fine adjustment. So the patient experience is awesome, because they're like, wait, when I did my denture 14 years ago, I had to come 12 times to the other dentist that I was at. And that still occurs, believe it or not, because there's something really interesting that I want to bring up about the mandible. So the next thing is that there's no inconvenience to the patient or family for multiple visits. Remember, most of these people, maybe they can't come on their own. Maybe they can, but I can guarantee you they're at their awesome golden years of their life. They don't want to spend it in a dental chair. They want to be hanging out, having a beer, playing poker, bingo, whatever they want to do. So you're basically changing their inconvenience to making it really convenient for them and or their family, that they have to take work off and do that. So it is that easy. It really is. But your data needs to be correct, and you have to understand where you are at all times when it comes to that. So let's go through a little bit of analog history and digital methods. And I'm just going to go quickly through this because I don't want to bore you, but I think it's pretty neat. So wooden bone, 8th century. Some say it started in Japan with cherry wood. The Goodyear Dental Vulcanite Company actually started before Goodyear did. Vulcanite was invented and patented in 1852. The patent was awarded to Goodyear in 1864. And you can see way before there were tubeless tires, there were vulcanite dentures. PMMA was invented in 1928, and it wasn't really evaluated till 37 for dentistry. And basically by 1946, or just after the war, most dentures were made out of PMMA. The pink fiber was introduced in 1951 by Dr. Pound. And I'm sure all of you know a little bit of dental history and know Dr. Pound. What's really interesting is printers and print materials. So the first printers came on the market in 1984, 1985. I did my first print in probably 1997, 98, right around there, maybe even later, maybe 2000. The first print denture-based materials that were FDA approved came in 2015. So let me just go back a slide. 1928 PMMA, 2015 material that's printed. And today we have a plethora of material processing techniques. So, but what I want you to see is that from 1928 to all the way to 2015, there has been no advancement at all. Maybe a little bit of advancement of instead of hand packing to injection, but here we have a whole bunch of methods. So Ivoclar and Avident have a milling method where they can mill the teeth and the pink all in one shot. Amann Girrbach and Vita have a process where you mill the pockets and then you mill the teeth separately, which are denture teeth, and they go in. And then, of course, Asiga, Accurata, and a whole bunch of other companies, Shining 3D, Sprint Ray. There's a whole bunch of companies that do printing. So some of the new material advantages. Materials like traditional heat cure acrylics can shrink up towards 7%, and they shrink usually in the palatal area a little over 250 microns and around 4% linearly. Just to give you an idea of what we're talking about. Here's a question for you just to think about. Why do we have a post dam? It's because acrylic shrinks. That's why we have a post dam. And we try to get it near that vibrating line. Your tissue moves about 25 microns, which is 1 decimal point over. So it would be to the left. So it would be 0.025, 25 microns instead of 0.25, which is 10 times larger than that. So print materials shrink less. There's always a little bit of shrinkage, but that happens in the actual printer when the photo initiators work. They have better color stability. That's what we've seen. Milled acrylics, when you're milling them, they don't shrink and practically have no residual monomer, which is great for your patient. The excellent part about this digital idea is try-in dentures can be visualized. It's like a wax try-in. But remember, I'm in Florida and it's about 95 degrees now. So what happens is when you're sending a case, sometimes, especially in a UPS truck or a FedEx truck, they'll melt, or you're trying to take a bite registration and the teeth move and now you think you're in the right place, but you're not. But you don't have to worry about that anymore. No more temperature problems, no more worries about teeth movement. So how do you affect that try-in denture? You actually have the lab, or you can print it yourself. You go ahead and print it and you grind it in exactly to where you want it. Once you get that position, game over. It's finished. The whole process can be completed. The limitations for aesthetics are endless. Precision and time efficiency are a key to the digital process. They're the hallmarks and the goals of digital because they're precise and extremely time efficient. And the visits to the clinic are less. The process happens once at the initial visit. So just think about it. You book your patient for an hour. I know nobody wants to spend an hour on their patient or 2 hours or 5 hours, but you take the amount of time that you actually need to do an excellent job. And if it's an hour, great. If it's 2 hours, great. But once you do that work and you've established video and you've established all the important information that you need, you never have to do it again because we have the position of the 2 front teeth and we have the position of the condyle in the correct place in relationship. Troubleshooting. We'll do a little bit of troubleshooting. Some of the issues of fit and aesthetics. One of my good friends, practically a brother to me, his words are, the best thing about digital is it's 100% accurate. The worst thing about digital is it's 100% accurate. I can promise you that my errors on your digital model will be 100% wrong. Perfectly. They'll be perfectly wrong. So what we want to do is make sure the communication between the lab and the dentist, or the lab and the lab in-house lab, have communication. Basically, the general issues that we have in digital dentures today is not to fit to the surfaces. I can show you that we're within microns to the surface after processing, but it's almost bite registration. Hey, the denture the bite's not right. The teeth are too far forward. And the reason I'm saying that is because usually when you tell a patient that doesn't understand dentistry or is not a dentist and you ask them to bite down, what do? They move their mandible forward. So now we've corrected something and the teeth are too far forward or they're biting. So we understand that the position of the maxilla to the mandible in an edentulous patient is the biggest thorn, hindrance, and most difficult to achieve. It's difficult to understand in the dental industry. It's so difficult. And a lot of you going, I got a good handle on it. Trust me when I tell you, if you see the things that we see, you wouldn't believe it. And this is not a downplay for a dentist, because if there's anybody that understands the difficulties that you're going through, it would be the lab, because we understand what's necessary for the manufacturing. And what we're trying to do is help you to make it as easy as possible for you. So my tip or my advice to you is take a course at Pankey, take a course at Dawson's, take a course with John Coyce, take a course at Spear, take a course with Dr. Masad. Dr. Masad does courses all the time. He actually perfected the Gothic arch tracer, and it's not that complicated once you understand the concept of how it actually works. Digital data, unless I actively change it, move it, smooth it, cut it, put holes in it, and change the surface, it's perfect. So when you get something back and you see that it fits on the model, that's all we have. That's all we've been given. And that's never going to change. So what we have to do is communicate and be partners in a way that we can understand what's coming to the lab and how we can help with some of the pitfalls of digital impressioning. So back in the day, dentures with porcelain teeth, I'm going to talk a little bit, we were talking about fit and aesthetics. So porcelain teeth had what's called a diatoric hole. Some of you may or may not know that. The anterior teeth had brass pins. This was strictly mechanical. So even in acrylic, in PMMA, it was just mechanical, going around the pins and the holes. Traditional process of denture teeth with packed or injected acrylic. One of the reasons that you've seen a tooth come totally clean off of the base and you can actually see the seat of the tooth is because there was wax left on the teeth. And so there's no chemical bond, because acrylic bonds to acrylic chemically. And this would be the main cause of a tooth popping off outside of an incorrect or what we would call a heavy bite. But the new materials are so much better. I mean, these materials today are 100 times better than they were 2 years ago. The chemistry allows stronger bonds. The materials are less technique sensitive. Bonding agents like Ceditech, I like using it. That's what we use. Assembly. I hope I'm not going too fast, but I want to try to give you as much information as I can for this hot topic right now, which is digital dentures. I can tell you this, please, please, please follow the $1 million instructions that are accompanied with the IFUs, or the instructions for use. These companies have paid millions of dollars. They understand the chemistry. Just follow the rules. You can't toast faster. It's going to toast when it gets toasted. These materials today are advanced and actually can change a flexural strength for the better. So follow the instructions. Make sure you post-cure properly. If you're doing this at home meaning your clinic, because you're there all day, the way a lab is, a lab guy's always at their lab, you need to understand the spacing and the gaps that you need for the parts to fit unhindered. And that is not a press of a button, people. I can promise you that. It's not that easy. It's not as easy as you think, but it is. You can accomplish it, but you have to understand where you're starting and where you want to be. So you can either use the print material which is the pink base, or a bonding material specifically made for this process, like SediTech, to help with gluing or bonding to the denture base. So you have your teeth, you want to bond it to the denture base. That's one way to do it. You can use a bonding agent like SediTech, which is actually very specific to bonding, because now you're using these two materials and you're using this photo initiator, which is a light-cured material. So light-cured materials need bonding agents. They're very similar, if not exactly the same, like your composites when you're doing a composite filling. Except that the denture material or the print material is a urethane-based poly methyl acrylate. So we want to make sure that we understand every step carefully and do it the right way. Don't speed it up. If you're doing a digital denture, remember, you have the digital denture and you can rearticulate to check the occlusion. The way you can rearticulate is you can print the models. And if you print your models, you have them right there in the hand. You're going to guarantee your precision. This is what an edentulous is. So remember, the two green parts didn't have the khaki green posts. They were floating in air at the perfect position that we received it digitally. So this is how we go ahead and double check our work. Properties to look for in printable or milled dentures. Basically, color is really important. Our standards are through real life experiences. I've been doing this, let's see, I said I was 54. I'm 54 and 9 months in the dental lab business. I think I was conceived in the lab. Tooth material. Are we milling? Are we printing? Are we using denture teeth? What are the tooth properties? Are they going to hold up? Are these new materials good? Can I polish the base and teeth, or will I have to use a glaze? How much is the cost of the equipment needed if I'm going to do this? How long does it take for manufacturing and assembly? So these are all things that you want to understand the properties and how to get the properties that you're looking for printable or milled dentures. Polishability. You want to make sure that they're polishable. A lot of print materials are not polishable. So using glaze, you may need to reapply it a few times. Polishing really allows for a much more smooth feel and comfort for the patient. We actually go through 4 stages of polishing, and I'm going to show you stage 1, stage 2, Scotch-Brite and silicone rubber wheel, and then pumice cotton wheel and polish with a cotton wheel. So here we go. This is what we start off with. We do a visual check, make sure everything's good. We go to stage 1. We use the Scotch guard. We use a silicone wheel to make it nice and smooth. We then pumice. We then go ahead and polish. Of course, you're going to need some polishing wax. And this is the result. It's phenomenal. You can see how beautifully this thing gets polished. And it really feels good in the patient's mouth. This is what we use for all of our denture assembly. I like it a lot. It works for us. We really haven't had any failures. The ones that we did, I promise you, we made a mistake because we went a little too fast. So troubleshooting issues of fit and aesthetics. I want to also talk about cameras, composites, and scanners. So, number 1, this is how we troubleshoot. I did this denture in 2016 at a Spear, and we did this, if you can notice, to the patient's number 7 area, there's a little nub of a tooth. It was an immediate, it was a 1 visit. You can see we designed it with a photograph, which is very important today. There is actually no reason to not give a photograph to your own designers or to your laboratory. And this is the final result. So let me show you the process of what we went through. You can see nice profile. This all happened in 1 shot, 1 visit. This is an immediate denture. So here's the denture. This is the beauty about digital. We can actually change things. We don't like to change them, but sometimes when you're using an OmniCam in 2016, you couldn't get all the data. So this is what the patient had. This is what we started with. You can see that the denture's short, but you can see that we extended that area. So we copied and pasted a whole bunch of material there. This is what the patient looked like. We were fortunate enough to have the CT scan, so we showed them kind of what our setup was, and you can see how nice the teeth contour. And obviously, you can see how nice the final result is. So, canted. I would never know if your patient had a canted smile line or canted teeth if I didn't see the picture. And it can't be a picture at an angle, because if it's at an angle, I cannot see the midline. So it never needs to happen again. It's something that could be eradicated. Just take a photograph. It's a simple picture. This is actually one of the best photographs I've ever seen. It's perfect. This is the patient standing up straight, even though it's not. Of course, it's a professional photograph, but they're standing up straight, not sitting in the chair. Both ears are showing. The patient's head's not tilted left, right, up, down. It's actually nice and square. This is exactly what we're looking for, because even in this situation, Justin Timberlake has a canted smile, right? And so, but you look at his teeth and they kind of match his eyes, and it's actually a really nice smile. I would change a few things, but at the end of the day, this is the kind of picture we're looking for. But if you're going to use your iPhone in the office, which is very easy to use, there's a little setting inside that's called lens correction. Turn it off, because it makes the photographs anamorphic when we bring it into our world in the lab in ExoCAD. That's what I use. If you send it into 3Shape, you'll have the same problem. So it really helps with aesthetic design. Make sure that the patient is straight and upright. You can use a fancy camera if you want. You don't have to do any lens corrections, just to make sure it's in focus and you're, square with the patient. So the patient's face is square with the lens. We have our custom additive contour and color. So we can make some really amazing dentures today. You can use Amaris from Voco. It's a very nice product. Same thing with Annex Dent. They have a whole bunch of different gingivas that you can use, or GC America. These are all excellent tools to enhance the denture look. So these composite materials have some great advantages for the printed denture, because the printed denture is blah. There's really no fibers in it. It doesn't really look that natural. It's all one color, kind of like the older dentures that your grandma would have. They can enhance contour for a more natural feeling. They can enhance color for a more aesthetic value. They look way more realistic. And the denture is more personalized to the patient's needs. And it really isn't your grandma's denture anymore. This is a denture made by a technician that's 100% printed. And you're like, what? Look at that incisal edge. But you can see on number 10, or the lateral on the left side, you can see that there's a little bit of a white stain there. There's some blue and pink, and it looks gorgeous. It's a beautiful denture that we can customize in short order. The other thing we actually talk about too is 3D facial scanning. So it's really neat that you can have a piece of equipment like this in your office. It takes a half a second. We have it here at the lab, so doctors do send their patients here, and we do a face scan, and takes a half a second. It literally is just a snap of the fingers. It's very easy to bring into any design software, and it's extremely helpful like this. So when you see a photograph like this is in 3D. This is 3 different shots of the same picture, but it's not a 2D picture. As we're rotating it, it's actually in 3D. So I can even turn the head more to the right or to the left and actually see the profile and where I want to place it. Of course, this patient doesn't need a denture. But for denture patients, it's a real easy way to sit down and talk with them and get them to understand what they'll be receiving when they have this kind of photography. And again, some of these things that I want to reiterate is, number one, your data capture is extremely important. If you believe that you've managed the mandible in the correct place, when the denture comes back from pretty much any lab in the country, it will be correct, no matter what, because the only data they have is the data that you sent them. So if there's any bite scenarios that you're having trouble with, it's because you may have missed it. And there are ways to, like I said, there are techniques of learning how to make a better denture, because in the end, I've been doing this for a long time. All I can tell you is, in the end, the denture is the gateway drug to implantology. And if you do it extremely well, they're either going to keep their denture forever, and that's great because you have a successful, happy patient. You have a successful case out there. And if you do it really right, really, really right, and they are really thinking about, I don't really want to pull my denture out. It's embarrassing. I need to get it relined, or whatever the situation may be. Now, what you can do is actually move them towards prosthesis. And guess what? Now that you've done all your records correctly, there's not a lot of work to do on the back end to have a very nice process. I hope you enjoyed the topic. I hope I didn't go too quickly. Again, I want to thank you all for spending 1 hour of your precious time with me. I want to thank all the corporations that support Viva Learning, and thank you very much. Have a great day. I'm going to answer, let's see this. So one of the first questions that I got is how to set a new vertical and if existing dentures are worn down to both arches. Great question. So if you have a vertical and they have existing dentures, remember, we have a starting point. So what you can do is use something like a Lucia jig, even though, you have to take this with a grain of salt, because what I'm trying to do is give you some of the tools to open up that patient's bite to get him to a particular position. Obviously, the best thing to do is use a Gothic arch tracer. And again, please look into it. It's not really that complicated. But what you can do is, even if you have the patient and you scan the dentures in 360 degrees, you can send it to the lab, tell them to open up the bite 3 or 4 millimeters as a test, and you can go ahead then and grind it in. If you want to be more exact, then what you would do is either use cotton rolls, a little bit of putty, open them up, and you won't know until you get the denture back, because you need to make sure that that position of the mandible is lingual. I hope that helps. Second question here. Let's answer this. My experience with the resin is that it doesn't bond reline material. Over time, the milled dentures, can the milled dentures be relined? If you do, what do you use? Okay, so if you use a milled denture, if the denture is actually milled and the laboratory is telling you it's milled, it's actually PMMA. So it's regular acrylic. There's nothing special about milled acrylics. So you could use the standard material. I know that there's a lot of companies that make reline materials like the Tax. I know that Voco makes a hard material that's relinable. So those ones work. If the denture is printed, then you have to use that adhesive. You have to use a bonding agent or it won't bond. So what we tell our doctors is, because we do a lot of printed dentures, we actually tell them to use the bonding agent and use I think it's called Eufy gel. I'm not sure, but they use a vocal product. It's a workhorse. I think, let's see if there are any other questions I can ask. Let's see. If you have an existing denture, that is great. Would sending the denture stuck together in the patient's bite be enough as a record? Absolutely. You can do that. But remember, if you don't have a scanner, that's totally understandable. Today's scanners are fairly, I don't want to say inexpensive, because 10 grand is still 10 grand, and 25 is still 25. But if you did want to have your patient allow you to take them and send them, then yes, sending them together, make sure that they're packaged well. If that's the bite registration and you've taken wash impressions, we would then at the lab first scan them in as soon as they come in. Then we would pour the models just to have it as a secondary reference, but we would 98% make the whole denture fully digitally, and you'd get, we would send out the dentures back the same day because they'd be scanned, and we would send the denture out 3 or 4 days later that's completed. Let's see. This is a good one. What's the best way to scan the tissues with the scanner? That is actually really tricky, because the tissue today is not much of a problem, especially on the upper arch. The maxilla has topography, which is rugae and tuberosities and a lot of nooks and crannies and curves. On the lower arch, it's a little bit different, because generally the lower arch is a lot smoother. So the scanners have a hard time capturing that. But some of the new ones, like 3Shape, the Shining Aoral 3, the Prime Scan, they're actually pretty good. But what I'm going to tell you is, it's not really about scanning the tissues only. You also have muscles. You also have frenums that you can't capture. You can't capture them digitally, because as soon as you move, that scanner is going to actually retake the new position of the frenum not extended, but pulled away or overextended, right? So that's why it's kind of important for a denture to have some kind of proper molding to understand the musculature and what it's doing moving the denture. What system do you use for the 3D photo? We actually use the Ray. We have the Ray Face here. There's a few good ones out there. Some of them are extremely expensive. I think, honestly, for this particular situation, it's overkill. But there are a lot out there. I think Dr. Kim, he has a 3D photograph thing that works really well. It uses a real camera, but you got to be a camera guy. Like I said, this thing, the reason that we have it here is it's extremely easy to use. Okay. Actually, this one's really good. This is a great question, and I think I'll end with this one. I don't want to overextend my time. What about the selective pressure technique, which can be done manually? I suppose this is not possible on digital impressions. Any alternatives? Yes. So just because you have a digital scanner doesn't mean you forget all of the analog world. And just because you're doing things analogly and you own a scanner means that you forget everything about digital. So in this selective pressure technique, what you can do is actually take your impressions, do your selective pressure, scan it, and now you have exactly what you've done in your work. And like I said, this is the beauty of digital. Once you've done this hard work of doing the border molding, selective pressure technique, you can do hybrid techniques. It doesn't mean you're stuck in one path. And that's kind of what makes us a little bit different than a lot of labs out there, is that we actually understand that there's not one way. There's one way, which is called a good impression, but every other way is getting there is the important part. So that's kind of that's the whole thing. And you remember, so when you're doing this selective pressure technique, what you can do is digitize it. We send you a quick little printed denture, regardless of the teeth, and you can use that as a custom tray if you didn't want to utilize it with what the patient had existing. Maybe they did, or maybe they didn't. I think we're okay here. I'm just trying to read a question here. There's a question here saying, would you have scanners in every dental office to scan for dentures? Yeah. I don't know why I wouldn't. Of course, I would want to have a scanner in every dental office, because remember, the digital scanner doesn't prevent you from doing anything in the analog world. It only allows you to transfer what you've done in the analog world to the digital world. So you can either do a digital scan, or you can do an analog impression and then scan it. And remember, we're here. You can always contact us. We can help you in any of the other questions that you may have. Yes, I did mean scan impressions for the selective pressure technique. Thank you all very much for your precious time. I really appreciate it, and I hope you enjoyed it, and I hope there are a few things that you can take home and utilize to better help your patients and help them really start enjoying their life by being able to eat a nice steak or an apple.